everyone. Are you ready to learn about GLP-1 agonists and their effects on weight loss? My name is Sam Cook, and I am an MD PhD candidate, and I am joined by my co-host, Carter Gottlieb. Carter, are you ready to rock and roll?
Oh, I'm ready.
Okay.
So when we're talking about weight loss drugs, we're referring to things like Ozempic. These came to be because they were diabetes drugs, and the patients that were put on them, unlike other diabetes drugs, started to lose weight. So then they started studying it in people who were overweight or obese, but without diabetes, and found that it was very effective in lowering their weight.
So GLP-1 agonists are also known as glucagon-like peptide 1 agonists. And this is slightly confusing because glucagon-like peptide is not like glucagon at all. Glucagon is released by the pancreas when there is insufficient blood sugar.
The GLP agonists bind to the receptor that glucagon-like peptide 1 binds to, and this has different effects on the body. It delays gastric emptying, but it also goes into the brain where it reduces appetite, and that's the primary way that GLP-1 agonists are going to induce weight loss, is by just making people that use them eat less food overall.
GLP-1 agonists also do inhibit glucagon excretion. So you're going to be inhibiting the processes by which your body, through homeostatic mechanisms, raise your blood sugar. So it's going to keep your blood sugar low. We see that there's also an effect on HbA1c, which is a marker, long-term marker for diabetes and elevated blood sugar.
Yeah, so there's Ozempic, which is semaglutide.
Wegovy.
There's Mounjaro, which is tirzepatide. And Wegovy is also semaglutide.
What is the difference?
The difference is the dosage that it's prescribed at inside your auto-injector. The difference between Ozempic and Wegovy is one, Ozempic comes in a little vial that you're going to take your own insulin needle and you're going to inject your dose. But Wegovy, it's made for people who maybe don't have experience with doing that. They're not been diabetic. They're for a significant amount of time. So they come in an auto-injector. And the dose is also different. So with semaglutide, I believe the dose for diabetes is 1 milligram per week. But Wegovy, it's a graded scale. So you start at a lower dose and you end up at 2.4 milligrams per week at the end of it. And use an auto-injector so you don't have to worry about pulling the right dose every time and things like that. It does it all for you. Just stab yourself in the thigh.
And what is the purpose of tapering up?
The purpose of tapering up is that with semaglutide, Ozempic, or Wegovy, there are some side effects, primarily nausea. So if you just inject 2.4 milligrams, like a lot of people will just vomit.
Yeah.
And it's a really long half-life, so like if you inject too much, then you'll be sick for a significant period of time.
Yeah, this is true, especially with like the later generations. The half-life is. We'll get into that.
So Ozempic isn't the only medication for diabetes that's been shown to cause weight loss. So there's also a class of drugs that blocks alpha-glucosidase in your digestive system, which is an enzyme that breaks up sugars and carbohydrates, so sucrose and starches from your foods. And this is a very popular diabetes medication in Asia. It's not used as much here.
Why is that?
The only explanation they gave in this review that I was reading was that people in Asia eat more rice, so that they thought that acarbose and miglitol would be more effective in populations that eat more carbohydrate. But we eat plenty of carbohydrate.
That was about to say, I was like, what?
People eat hot Cheetos like as a staple. So,
yeah, for breakfast, bro. You ever been to a public high school?
Yeah. So my opinion is that this class of drugs is underutilized, and also they're underutilized because there's this because of the side effects that they cause. So when you start taking acarbose or miglitol or voglibose, these carbohydrates in your digestive system, they don't break up, so that they get into your colon where they're fermented by bacteria. Those bacteria produce gas, so you end up more gassy and a little bloated, and you can get discomfort in your GI tract. But the thing is that this is temporary, and there was a long-term study that looked at it, and after a couple weeks, almost everyone had side effects. They were all bloaty and gassy.
Yeah.
But then after months had gone by, what happened was that the alpha-glucosidase in the beginning of the digestive tract was blocked. So then the expression of this enzyme increased throughout the digestive tract. So you end up absorbing it, but later on. So you get a slower absorption and less peak blood sugar when you take acarbose. And
does that blunt the effects of weight loss?
Well, with acarbose, the weight loss is not significant. With miglitol, it is. And one of the reasons that I think it might be is because miglitol is absorbed by your digestive tract into your bloodstream. So it could have some sort of systemic effects. I don't think it's well known or well understood, but miglitol does cause some minor weight loss compared to acarbose, which doesn't. Then there are the flozin drugs. So we have empagliflozin, dapagliflozin, canagliflozin, and these are drugs that block SGLT2, which is a transporter. And if you imagine your kidney is sort of like a filter for your blood. It makes urine by filtering your blood. It goes through, and this filter doesn't let large things in, like your red blood cells and
That would be bad.
other things, right? That would be bad. It happens, but that's a bad sign for your kidneys if they're unable to filter the cells. But smaller things like sugar molecules, they can get through the filter of your kidney, and we don't want to lose our sugar. Just like from an evolutionary perspective, that would be a waste of energy, and historically that wasn't a huge problem for life. But now it sort of is. So there's a pump, and it takes the sugar that was filtered through the blood into the urine, and it pumps it back into the blood so that we don't lose it. And that's called SGLT2. And so there are this class of drugs that block this pump so that you can't pump the sugar back into your blood. And so it goes out into your urine, and you join the Sweet Pea Society.
You pee sugar.
You pee sugar, and then this is very helpful for people with diabetes, and it also has benefits for the cardiovascular system. But in addition to that, it can cause weight loss because you're losing, and at a decent dose of this class of drug, you can be losing up to 100 grams of sugar in your urine every single day.
What is the daily recommended value for carbohydrate?
So the thing about this, I think what you're getting at is like
how much of an effect does that really have if you have like a standard Western diet? Like if I have, you know.
So most of the sugar that's in your blood is not from the sugar that you consume. It's produced by your liver through a process called gluconeogenesis. So even if you're not consuming sugar, you can still have high blood sugar, and you can alleviate that through something like the paclitaxel, because the sugar that your liver is producing that can't go into the cells because of insulin resistance, that's building up in your bloodstream and causing a lot of damage to your cardiovascular system and body as a whole, that sugar can be peed out.
So Carter, how can we blunt gluconeogenesis and really maximize the benefits of those Flozin drugs?
Right. So if you are someone who is diabetic and your diabetes is not well controlled on one of these drugs, so this is a sort of a different situation than for weight loss, because there aren't a lot of studies where they put people on multiple drugs in order to induce weight loss. But for diabetics, there's plenty. So there's plenty of studies showing, for example, SGLT2 inhibitors, the sweet pea drugs, with metformin, and in combination, they are more effective. So you can block gluconeogenesis, creation of sugar by your liver, by taking metformin.
Are there any side effects that people should know about regarding these drugs?
So we talked about the side effects for acarbose, which acarbose, miglatol, and voglibose, which are going to be GI upset and flatulence and gas. For the Flozins, the sweet pea drugs, the side effects are generally going to be increased risk of UTI, urinary tract infections, because now there's sugar in your urine, and bacteria and fungus can consume that sugar, and they can proliferate in your urinary tract. So this is especially problematic in women. Increased risk of UTI from taking the Flozin drugs, the sweet pea drugs.
And also dehydration is something to take into consideration, because you are pulling all of that sugar into your urine, and where sugar goes, water is going to follow. Mm-hmm. So being cognizant of that and then being well hydrated.
Under anesthesia, and this is sort of getting very particular, but it can increase the risk of euglycemic ketoacidosis. it can increase the risk of euglycemic ketoacidosis.
Okay, we have all of these diabetes medications that are seemingly effective at not only treating diabetes, but also potentially conferring some benefits regarding weight loss. Why do we need GLP-1 agonists?
Well, we need GLP-1 agonists because they're the most effective and have the least side effects. So traditionally, if you went to a doctor, what are you thinking of?
Like, I don't know, like bone density loss. Like, there are like also.
I'm talking
relative. We're going to get into it, but.
So what I'm talking about here is relative. Right? I'm not saying they have no side effects.
Yeah.
I'm saying that compared to going to the doctor, 30 years ago, and you saying, I need to lose weight, and then they prescribe you Desoxin, which is literally methamphetamine. And
the good old days.
Right?
The good old days.
And your blood pressure goes to the roof, and you have an aortic dissection, right? Yeah. That's way worse. And then you just also aren't normal.
Yeah, that's
when
fair.
You're taking it. So it has been just a breakthrough, because although there are side effects from taking GLP-1 agonists for weight loss, they're way better than anything we've had before. That either doesn't work that well or is just a stimulant that is going to wreck your mind and body.
Yeah. There are GLP-1 agonists that are FDA approved for weight loss, and there are other GLP-1 agonists, namely Mounjaro, that are currently that are going to end up being approved for weight loss. Do you want to tell us a little bit about that, Carter?
Yeah, so there is tirzepatide. That is gaining approval. And I actually talked to a Eli Lilly rep in the airport. He came up and complimented my shoes, and then we talked about GLP-1 agonists, because he was a rep for tirzepatide.
Where was he going? What was this man doing?
He was going, I don't know.
Okay.
But anyway, I was talking to him, and he really wanted me to be an authority to his wife to tell her that, in fact, In fact, Mounjaro is better than semaglutide. See, honey, I was right.
Oh
my
my
product is
God.
better. my work has meaning.
What an interesting dynamic. I'm glad that you found yourself like fully inserted into someone's marriage. That's great.
He was so happy that like someone knew about these drugs in the airport. He got my number.
I just can't imagine why his wife would have such an opinion.
I know,
you
because I should have asked her. She was just completely quiet and annoyed the whole time. But I should have been like, "Are you a rep for Ozempic?" Like,
You know what
is
this
some
tells
sort
me?
of-
That he doesn't shut the fuck up about tirzepatide. That their home life is dominated by tirzepatide talk.
Oh yeah, keep that out of the bedroom.
Yeah.
So there is one FDA-approved GLP-1 agonist that is semaglutide, and as we discussed, the difference is the dose and the administration. But you can use Ozempic, and Ozempic is prescribed off-label for weight loss, and it's pretty much identical if you match the doses. Then after that, we have tirzepatide or Mounjaro, which is currently in human clinical trials and is likely to gain an approval pretty soon as the next FDA-approved weight loss drug under the GLP-1 agonist category. And
What is the holdup? Do
right.
you know?
I think the holdup is just that there's a timeline for developing drugs. I don't think there's a specific
Are they like
concern.
they're, like in the middle of a separate clinical trial demonstrating efficacy and safety for weight loss, though, right?
They're in a phase 3 trial, I believe, for weight loss. So they've shown that it's safe. They've shown the dosages that would be effective at, and now they're just doing a much larger scale trial to show that it's effective for weight loss. And when that data is finished, they're going to go to the FDA, and the FDA will likely approve it because it looks pretty promising. But we'll see what happens there. The benefit of tirzepatide over Ozempic, semaglutide, is that there's some evidence that it may work a little bit better than semaglutide. So there was one study where they directly compared Ozempic versus Mounjaro. And in this study, it wasn't exactly fair because they compared 1 milligram of semaglutide, which is sort of a low dose of Ozempic, to the regular to a 15 milligram dose of Mounjaro. So the dose of semaglutide that you would use for weight loss is typically a graded scale. So you start at a low dose and you move up to 2.4 milligrams. So comparing 1 milligram of semaglutide wasn't exactly fair. But at the time, that was the dose that was most commonly used of semaglutide because that's the dose that's used for diabetics. And in that study, tirzepatide did perform better. The group that was on tirzepatide lost more weight. And then there's a third GLP-1 agonist that's in the pipeline for weight loss, and that's called retatrutide. And retatrutide just appears to blow the other two out of the water in terms of the amount of weight that you can lose with this drug in even a shorter period of time. So I'm really looking forward to seeing some of that data.
One thing that I really want to hammer home is that GLP-1 agonists are unique in their ability to offer sustainable weight loss. The diabetes medications that we mentioned previously, the Flozins and metformin and miglitol, voglibose, acarbose, all of those alpha-glucosidase inhibitors do have studies that show, there's a modest amount of weight that is sustainably lost. And I keep saying sustainably because when you are looking at someone who is, let's say, like crash dieting and over-exercising, they're kind of just immediately having these huge caloric deficits. They're losing weight rapidly, of course. But as a result, they have this rapid endocrine shift, which will cause increased appetite. It'll rapidly diminish muscle mass. And it'll also increase the efficacy of digestion. So your body's ability to extract more calories from the food you consume. So this all kind of goes against that weight loss that you were initially able to achieve.
Absolutely. I just want to mention, though, that loss of muscle mass is also a problem in people who are on semaglutide. That's a caloric restriction problem, whether you're restricting calories just manually or you're using semaglutide to help with that. You're going to lose a significant amount of muscle mass, which is why it's really important, whether you're on semaglutide, whether you're just dieting and reducing your caloric intake the old-fashioned way, is to eat a diet that's high in protein and also to do resistance exercise to try to maintain your muscle mass as you lose weight. You're going to lose muscle mass as you lose weight, pretty much no matter what, but you want to maintain as much as you can because in the long run, that muscle is going to burn calories. And so if you lose all your muscle mass, you're going to end up having a lower resting metabolic rate when you are at a lower weight, and it's going to be easier to gain that weight back. So it's very important to do what you can to maintain your muscle mass, whether you're on Ozempic or whether you're just dieting.
And with that, would you like to get into our meta-analysis?
Yeah, let's get into our meta-analysis.
Okay. This meta-analysis, and Carter kind of alluded to some of the problems that physicians, researchers come across when they are trying to compare GLP-1 agonists to one another. And this is true of all drugs when you're trying to look at efficacy. The name of this paper, I'll start there. The name of this paper is GLP-1 Receptor Agonist, an updated review of head-to-head clinical studies. And this was published in Therapeutic Advances in Endocrinology and Metabolism in December of 2021. The kind of review this is, as I mentioned before, a meta-analysis. So it basically compares a bunch of different studies to one another and hopefully offers some conclusions. GLP-1 agonists. So among them are exenatide, liraglutide, dulaglutide, semaglutide. The authors basically took various clinical studies and compared them head to head. And they also included this table, this lovely little table, if you guys want to follow along at home. But the various metrics that they're looking at are the date of approval. So we have like a chronological order for some of these drugs. As you can imagine, like later, newer generation drugs are going to be more effective and or have slightly different uses than earlier generation drugs. And I would like to point out that the first, or I guess like the oldest one in this study is April 2005, the more you know. And then they also have the percent homology to native GLP-1, which is interesting because I flagged this when I first looked at it. So homology means like. So if something is homologous to something, that means that it is like something. So their GLP-1 agonist has like homology to a native GLP-1 ligand.
Which one makes me lose more weight? More homologous or less homologous?
That's the question. See, I don't know. I tried to find it. Like if you have a peptide, if you have a drug.
Whether homologous to me doesn't matter. I want to see it given to somebody and how much weight they lose, or whatever your outcome is. Yeah.
This was a major like variable that they were evaluating in this meta-analysis, and they didn't provide any sort of rationale as to why.
Right. Well, I think that's important for people who are designing drugs, maybe.
But like, what? Okay.
Are we getting better results when the molecule is more homologous to the native peptide?
Yes.
Or does it not matter?
But that's the thing. They had the opportunity to evaluate that directly, and they don't. And then I tried to look online, like, why do you need, it is important when you are using protein modeling software and you're in like the R&D phases of, but that makes sense because if you're trying to make a small molecule that looks like a native ligand, you want it to look like the native ligand, and you have like algorithms that will predict whether this will be homologous.
We should mention here that tirzepatide is a dual agonist, so it might induce more weight loss. And so retatrutide, it's an agonist of the receptors for a GLP-1, GIP, which is the thing that I just mentioned, and then also glucagon receptor itself. So it's a triple agonist. Yeah. And so that's why it's more effective, because I think we're talking about homology now, and that could be one explanation for why something is more effective, but we're talking about something that's binding to multiple receptors and being more effective in the drugs that are going to come out later.
I wonder, because you can't just like take out all of glucagon, right? Like that is like an integral part of glucose homeostasis. You can't
just eliminate glucagon.
You can't just like eliminate
a glucagon antibody.
Yeah.
Well, I mean, no, we're talking about agonists anyway, so it's like it's as if we're adding more.
Adding more glucagon?
No, never mind.
Great. Homology, we don't know why it's important. I have an idea of why it's important, and I think that it's basically used as a proxy for how effective is this molecule going to be. Like the more homologous of a structure, or the more homologous...
I don't know. I mean, there's so many things that like the drug that it's mimicking just has such a higher affinity for the receptor and so much more effective. Like, I don't think homology would ever be like an indication of like how well it's working. I don't think
that's what I friggin' said originally. Yeah. And then I was like, okay, well, they had to include it for a reason, and then they don't specify.
I think
in addition to homology, they also include the dose and frequency, and Carter pointed out earlier that dose and frequency, when you're looking at clinical studies, matters, because if you change the dose or dosage, or like the dosing regimen, that can have like very, very pronounced effects on the results, especially if you're looking at specifically weight loss or diabetes management, like HbA1c, for instance. In addition to homology, they also include the dose and frequency, and Carter pointed out earlier that dose and frequency, when you're looking at clinical studies, matters, because if you change the dose or dosage, or like the dosing regimen, that can have like very, very pronounced effects on the results, especially if you're looking at specifically weight loss or diabetes management, like HbA1c, for instance. Right, and they also included the route. So most of these are subcutaneous, as we mentioned, and then oral semaglutide. That's the only exception in this paper. It's the only thing that is not administered subcutaneously, aka injecting yourself.
Under the skin, as opposed to like in a vein, right?
Yeah.
So semaglutide is injected. It can pretty much be injected anywhere in your body, but it's most convenient to inject it in certain locations that have more subcutaneous fat that you would be injecting into, and not many arteries that would cause bruising when you do it.
Cheek.
You could. I mean, you wouldn't want to.
Okay.
There are a lot of arteries like around the eye.
Oh, interesting.
Yeah. So you've taken off somebody's face. You should know that.
I have taken off somebody's face. I actually did a beautiful dissection when we had our face. Yeah. Basically, what I'm trying to demonstrate is that meta-analyses, one, are an excellent resource when you're looking at clinical trial data. They do generally a really, really good job of compiling all of the results of clinical trials, especially if you have a specific question that you're asking. So in this case, we're looking at weight loss, number one, but also management of diabetes. So the outcomes that this paper is evaluating all of these clinical trials on are HbA1c levels and weight loss, right? And I think they do a overall good job of that. They have beautiful graphs that show very clearly where there are significant differences between two drugs that are compared head to head. And that is the format for most of the clinical trials that are being reviewed in this meta-analysis. Is you have one drug, liraglutide, another drug, semaglutide, and they are compared head to head at their relative dosages and doses, like for whatever length of time. That is one issue. The patients in the study, their HbA1c levels and the weight loss is determined at the end of the study. And then there are 13, can I count? I think it's 13. It looks like 13 clinical trials are compared to one another. And what they have found is that in terms of decreased A1C from baseline, so from the start of this trial, our big winner seems to be wow, I cannot believe I did not color copy this. That's crazy. That's on me, coach. Exenatide.
So that's talking about, that's a way that you can measure blood sugar.
Yes.
So your blood sugar fluctuates depending on how recently you ate and the time of the day it is and things like that. But you can measure sort of an average blood sugar over the time by measuring someone's HbA1c.
Yeah.
And so that is very important measurement for people with diabetes, and it may or may not correlate to more weight loss.
Yeah, no. I'm just saying that this is what they were looking at specifically in this paper. I know we're interested in weight loss, folks. I'm not going to leave you hanging. In terms of weight loss, our big winner is, I still cannot believe I didn't look at this. I can't believe I didn't color code it.
And do we include tirzepatide and?
No, tirzepatide is not part of the study. I will say.
And neither is retatrutide.
We need a different meta-analysis.
we need to get tirzepatide and retatrutide because those are.
We don't have those, but this is mainly just used as an example when you're looking at clinical trial results and you want to compare things head to head. This is the meat. This is what I really wanted to say with this article: is that you can glean information from this, but it is very, very important to remember that we are comparing different clinical trials. These are discrete events that happen over whatever period of time the scientists and physicians running those clinical trials deemed was appropriate. So, for instance, and I'm not saying this is accurate because I'm not looking at the table. I'm just saying, for instance, your Duration 1 trial could have lasted 8 weeks. Your Award 1 trial could have lasted 12 weeks. But they're being compared head to head in this table. That can be inherently misleading, right?
Yeah. And the retatrutide study is shorter than the at least the biggest one we have, than the semaglutide or tirzepatide, and that would be a problem if it didn't look like it was as effective because it was a shorter period of time. But even in that shorter period of time, it was more effective. So
yes.
But that's definitely something you need to look at, is how long the study conducted.
Yeah. How long?
And a lot of the weight loss that occurs in GLP-1 agonists and other drugs is generally front-loaded. Like in the first couple months, that's where most of the weight loss is occurring, and then after that, you get pretty much maintenance, like much smaller rate of weight loss.
Yeah. And I feel like that's true for any kind of weight loss. Whether it's like diet induced or like SGLT2 inhibitor induced or metformin induced, like those.
Depends on the person.
Okay, so in addition to duration, though, I also wanted to point out that when you're looking at weight loss specifically, it is very, 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 very important to look at starting BMI, because in this study, again, this meta-analysis was relatively well done. But in this study, most of the clinical trials that were being evaluated had patients with an average BMI of over 30, okay? In 2 of the studies in which we see the least amount of weight lost, like in patients that were actually on the drugs, their starting BMIs were 25 and 26, respectively. So one of the studies had an average BMI of 25. One of them had an average BMI of 26. That is misleading. It's not intentionally misleading, but when you're presenting these figures like this, when you're presenting a graph, a bar graph like this, and you have all of these bar graphs, and then you have these little bitty insignificant changes, that leads the reader to assume that those drugs are less effective, but it doesn't necessarily take into account that those patients in those studies are starting at a lower BMI.
Yeah.
So, and we know that it is, you will see a more pronounced amount of weight lost in patients with higher BMIs. I feel like that's kind of intuitive.
Right.
So that is specifically when you're looking at clinical trial data that's focusing on weight loss, that's another really big thing to take into consideration.
Right. And beyond that, like what you're saying is like starting BMI and the timeline of these studies are the obvious things. There are much less obvious things too.
For sure.
Like even the season that this was conducted in, like people tend to lose more weight at certain times of the year than others. And
yeah, if you have a Thanksgiving, if you have an 8-week study that starts
Right.
November 11th.
And those are just the obvious things. There's so many things that we wouldn't even think of, which is why it's so important that we do have studies that are placebo controlled and have the same population, like randomized and doing different things. And so those are the best. And we don't have that yet for a lot of these weight.
And I know that there are like statistical models that you can use to like control for differences between clinical trials, but like even that has its own limitations. Like how do you control for differences in starting BMI? You
just got to select like when you recruit for your study, you have to recruit people that have a certain BMI.
Yes, exactly. Yeah. But short of redoing the entire clinical study, like how can you do a meta-analysis like this and control for something like that? Mm-hmm. I don't think you can.
Yeah,
I could be wrong.
You can,
Feel free to
you can
yell at
either
me.
not include the study, or if you have access to the data, you can filter it yourself and do kind of that analysis.
That is interesting too. Yeah, but normally when you're reading meta-analyses, they will give you exclusion and inclusion criteria.
But you wouldn't necessarily even want to combine data that way because of the different conditions that these, even if they were the same BMI, it'd be hard to do.
I mean, this is, again, an outdated study, so we don't have tirzepatide or
retatrutide.
Don't have that because I don't think that data has been compiled into a meta-analysis, at least in my very limited search. It hasn't been. But exenatide was the big winner for lowering HbA1c, and then I believe semaglutide, 1 milligram, was the big winner for decreasing weight. It is older, yes. Tirzepatide has been shown to be more effective, and retatrutide is even more effective. It'll blow your fucking socks off. Maybe. Can we curse on this?
I don't know. Maybe not. So people might not have access to this paper, depending on.
That's fucking true.
Access is the biggest problem, not even literacy. I mean, those things go hand in hand. Like you can't have literacy in a society that can't access the text.
Damn, son. Okay, that was an oversight on my part, folks. I didn't even take into consideration the fact that we probably have institutional, because this is SAGE.
Yeah, I don't condone piracy, but Sci-Hub exists.
It does.
Okay.
It's out there.
Sci-Hub.
Okay. That brings us to our next segment, where we're going to talk about the cultural implications of GLP-1 agonists and I guess, why is it in the zeitgeist? Like, why are we hearing about it? Why is it a big deal? What are the controversies that are surrounding GLP-1 agonists and their use? I think another thing that I was kind of hinting at, so the social media of it all and the pop culture of it all and celebrities coming out saying that they're using Ozempic or have used Ozempic for weight loss has also kind of infiltrated the average person's understanding.
And I think a lot of the criticism is because a lot of these celebrities aren't overweight or obese, so they're just using it. They had healthy bodies, and they're just using it, to sort of optimize to the fitness that they desire, that aligns with their standards of beauty. Mm-hmm. And so I think that's definitely an interesting question. In addition to that, there aren't studies in people who are non-diabetic and non-overweight or obese taking these drugs. So there's not a strong reason, I think, to believe that they would act any differently or be more harmful in these populations, but it's something that we just don't have an answer to. Yeah. And so that is definitely a concern. Whether people who are healthy weight and just want to be thinner, how that's going to affect their health short and long term, we just don't know.
Yeah, no, exactly. And another thing that I kind of wanted to bring up was that not only do we have celebrities that are very vocal about using Ozempic and other prominent figures that are using Ozempic for weight loss or for weight management, but we also have people that are speculated about. I'm not saying that is correct. I don't think that anybody should be, a accused of doing something. But what I do find particularly harmful is that, like, if someone is using something to modify their weight or to optimize their weight to the thinness that they desire, but they are purporting to have done it by natural means, aka diet and exercise, that can be pretty harmful to the average person, especially if you have someone.
So you're saying that people who are using Ozempic are setting a standard that's hard to achieve for people who don't have access or can't afford.
Yes, which is annoying because that's already being done. Like, that's already, like,
right.
that is, like, such a trope. And this is just, like, another layer, and you're kind of just like, fuck, man, really? Seriously?
Yeah. So it's another way that we're perpetuating, like, an unrealistic beauty standard.
Yeah, no, absolutely.
And often I see, like, a lot of people worrying about the smallest things in their diet, worrying about seed oils or something else. And if there are, like, negative health effects from that, they are so minor compared to the effects of, like, maintaining a healthy body weight. Either being too thin or overweight are both just very unhealthy. And so, but I also don't think that everyone needs to be so concerned with their health. You know what I mean? People can make the decision to enjoy life in a certain way, even if it's costing them in the total number of years or in other ways. So I think that's a very complicated topic and discussion. I think there's a lot of layers to it.
Yeah, no, absolutely. I think that is a really good point too.
But it is something that is important to discuss when we're talking about a drug that could potentially, make the world thinner. Is the ethical implications and whether it's even a goal that we want to achieve.
Yeah. That's a great point. Yeah. Do you want to decrease the
global fitness index?
Yeah, the global fitness index. I was going to say, like, diversity of body types, but you know, like, do you want everyone to kind of start veering toward this ideal thinness, or are we just going to end up, like, perpetuating to an even more drastic degree or, like, extreme degree thinness? That's,
right.
That's difficult. Especially eating disorders, for instance. One of the major health consequences for women with eating disorders is decreased bone density. Layer on Ozempic, what the
you got no bones left?
You got no bones. Like, that's scary. That's really scary, especially as, two people that are hopefully going to be doctors. That's, something that you have to, like, take into consideration when you're talking about, like, patient care and doing what's best for your patients. So.
But also, I think another interesting question is, like, if we do live in a world where we have semaglutide and perhaps even better treatments, like treatments that are way more effective that we develop in the future, and no one has to be obese anymore, right? That's a weird way to say it, but, like, anyone who chooses to be thin can, or in a certain body, in certain weight range. What's that going to do for, like, people who do want to be obese? Like, is obesity in the future going to be like the body modification scene? Like, there are going to be people, like, now that get piercings and, like, implants,
really
and now
yeah.
people are just going to be interested inherently in having high levels of body fat as, like, an alternative, aesthetic. Like, that's kind of an interesting concept.
That is an interesting concept. And I feel like there are people that...
Well, how would we perceive obesity then? Would we perceive that? I don't think we'd perceive it the same way we do now, that everyone is obese.
And I feel like we already kind of see that shift toward celebrating people that are clinically obese. Like, they are taking pride in their appearance. Right. They are not actively, like, working to maintain it. They might be predisposed to that body type, but they're definitely, like, celebrating it more and, like, lifting it up more. If you think that you yourself could stand to benefit from losing a modest amount of weight through pharmacologic means, then Ozempic or not any other. Read the meta-analysis if you have access to it.
Talk to your doctor.
Yeah, talk to your doctor. There we go. That would be a great place to start. Yeah.
Talk to your doctor to see if that's appropriate for you given your circumstances and your medical history.
Yes, and keep your eye on the pipeline.
So this has been the Double Doctor Podcast. I hope you learned something.
Yes.
And this is our first episode. So if you guys have any advice or topics you want us to cover or things you think we could have done better, then leave them in the comments, and we'll keep making more content.
Yes. Yeah, we're not gonna. We're in it for the long haul.
Maybe.
No.
If people say too many mean things to me, I'm leaving. Okay, bye.
Bye.